Okay, well, we will go ahead and get started. Welcome, everyone, to the UCSF Department of Psychiatry and Behavioral Sciences Intensive Services Grand Round Series. My name is Dominic Tarpey. I'm a member of the committee that helps put these talks together. And today we have a great initial talk for the academic year. This is our first talk, so I'm going to go ahead and introduce our speaker. Dr. Andrew Krystal is presenting today on sleep and suicidality. And Dr. Krystal is Vice Chair of Research for the department. As well as that, he serves in a number of different other roles. He is the Ray and Dagmar Dolby Distinguished Professor. He is additionally director of, I just mentioned all three of these, the director of the Clinical and Translational Sleep Research Program here at UCSF, director of the Dolby Family Center for Mood Disorders, and director of the Interventional Psychiatry Program in the department here at UCSF. Sorry, I have some noise in the background, but I think with that, I'm just going to go ahead and turn it right over to Andrew, and thank you all of you for participating. As with these kind of presentations, if you have comments and questions as we go along through the hour, please put them in the chat, and then we'll get to them as we go along. Thanks so much.
Thank you, Dominic. I'm going to try and share my slides here. Let's see if this works. Can you see my slides? Great. It's nice to see everybody and great to get the opportunity to talk with you today. I was thinking about this meeting. I realized I had no idea of who in the department attends the intensive services program, and now I know. So nice to see you all. So I'm going to give a relatively brief overview of sleep and suicidality, limited by the time available, and try to focus on sort of the research that's been carried out and sort of what the clinical implications of this might be. These are my disclosures. So I'm going to just talk about predictors of suicide in general. Review briefly some of the epidemiologic data that indicate that sleep disturbance and nightmares as well, actually, it turns out, are predictive of suicidality. And with the focus on the question is insomnia a modifiable risk factor for suicidality? I'm going to tell you about a double-blind placebo-controlled trial that we carried out trying to address this question, and then finish by reviewing the related issue of do insomnia drugs increase risks of suicidality? And the Dominic, do you usually wait for the end for questions, or do you have people ask questions as we go?
I think it's really the presenter's preference. So
okay.
If you want to wait towards the end, we can do that.
I'm happy to have people ask questions at any time, but I might not notice them. So Dominic, if you wouldn't mind surveying for chat questions or something.
Sounds
like
good. We'll do that.
So I think it's obvious that suicide is an important public health problem. It is become sort of extremely high in some age groups, including adolescents, and it's over half of the violent deaths worldwide at this point in history. And I was surprised to learn that it has a death toll higher than homicides and war-related deaths combined. There are a number of predictors that have been identified through correlative studies, through epidemiologic studies, that are increase one's risk of suicidality. And by the way, when I use the word suicidality, I'm referring to suicidal ideation, suicide attempts, and completed suicides, even though the research on those suggests that there are different predictors and different correlates that are linked to each of these phenomena, and they probably are best studied separately, although we generally don't get the opportunity to do that. And these are just correlative predictors that have been found. And you can all see the list here. I'm not going to read through it. I think the couple that I think are most notable are the idea of that there's an association with major depression, that should be no surprise to people. And that one of the well-known ones, and the one we tend to use in clinical practice, is the idea that people report that they have a suicidal ideation, that they have a plan or they have an intent, they have means, and these are the questions that we tend to review in our attempts to predict and to intervene. As you'll notice when you have sort of hopefully browsed quickly through this list, some of these are modifiable and some of them are not. So I think the extent that having major depression is one of the factors, that's generally modifiable, and that's one of the ways that one can intervene. There's a number of these have some potential for intervention, but most of them don't. Like your age, for example, if anyone can figure out a way to address that one, it would be extremely valuable for society, and I certainly would be personally a high interest to know. But so there has been a search for modifiable risk factors, and one of them is that people have been focusing attention on is sleep. And if you look at this question at all, you find tons of references suggesting that there are links here. There's more than 40 studies that suggest that there are associations between having insomnia or nightmares and suicidality, but specifically 40 alone indicate a link with insomnia. And that's number is probably over 50 now, because that review was done a few years ago, where I concluded there were more than 40. And these studies have had varying degrees of rigor with which they've investigated the question, numbers of subjects, care controlling for different things. But there are a fair number of studies now that have controlled for a lot of the important confounds, including depression severity and other factors, and the risk seems to remain after controlling for these things. There are 4 prospective studies of completed suicide that suggest a risk, a relative risk over 2. One of the things that I found very surprising when I started to get into working in this area is that insomnia is a more reliable indicator of suicidal ideation, suicide attempts, and completed suicides than whether people say that they're suicidal, whether they say they have an intent or a plan, which you would think just defies face validity. But apparently this is true, and I think we can understand some reasons why people might not report their ideation or their intent or plan. My experience has been when people really want to harm themselves, they don't tell people, because when you tell particularly mental health workers about this, they tend to take action and prevent it. And I've had the unfortunate experience of having 2 people commit suicide who I was managing in my career, and neither of them mentioned it. Both of them contracted for safety in the days before these completed attempts. And so I think one of the questions that I struggle with when I see this sort of set of correlations is, are these relationships correlative or causal? Correlations are, a dime a dozen. It's lots and lots of things to be found to correlate with each other, but it doesn't mean that they're in any way linked to each other. And I think the hope that insomnia could be a relatively easily modifiable risk factor that might mitigate a person's risks is only relevant if it's truly causal. So a group of us carried out a study to try to test the hypothesis of causality, and it was called the RESTED study. I did not come up with that acronym. Reducing Suicidal Ideation Through Insomnia Treatment Trial. And in this study, people were given 20 milligrams of fluoxetine open label, and these are people who are depressed and have insomnia and suicidal ideation. Everybody got open label fluoxetine, and then they were randomized to receive an insomnia treatment versus placebo. And we had initially proposed to use the insomnia agent azopiclone because there was some data suggesting that it might be particularly helpful in depressed patients. In fact, my conclusion from the available literature is that it is in fact an antidepressant. And I think somewhat wisely, the NIH review committee that evaluated this study suggested that this be changed to zolpidem because it's a cleaner test of the hypothesis that insomnia is a risk factor and not confounded by the potential antidepressant effect of azopiclone, because zolpidem has been studied rigorously and found not to have antidepressant effects. So in some ways, it was a particularly useful tool for us. And we had one-to-one randomization stratified by some of the important variables one would want to worry about. People had to be 18 to 65 years old and psychotropic free for at least a week and have a modest, at least, level of depression and suicidal ideation that was at least mild. We put in our proposal that, actually this is at least moderate. We put in our proposal that we would study, very mild suicidal ideation, and the review committee felt like that might not be of clinical relevance and asked us to study a slightly higher degree of severity, which of course increased our anxiety, but probably is more scientifically justified, just because very low levels of suicidality might not be sustained enough or significant enough for us to see effects of treatment. And so people also had to have insomnia by a couple of different diagnostic methods. And we had exclusion criteria, which included having an immediate intent or plan to harm oneself. And that was a complicated issue for this study. I'll never forget, I was in the unfortunate situation of seeing a patient in clinic and having to tell them in my clinic setting, in this research study, and having to tell them, I'm sorry, you can't be in our study, you're too suicidal. That is not a situation you want to be in. And we ended up deciding to modify our protocol to tell the person, to allow people like that in the study, but not use their data, assuming that they weren't so acute that they needed acute attention. If they did, obviously they ended up being hospitalized or sent to the emergency room or whatever, which happened with a few of the people in the study. This was a 3-site study, by the way, so I didn't see all of the people. And but I think this idea of having an upper limit, it makes sense but only really from the point of view that the person would need urgent, immediate attention. This was a double-blind, placebo-controlled trial, and so it's not that like everybody was getting insomnia treatment, but everybody was getting depression treatment. And one could understand a person who might put some hope in being in the trial as a way to get therapies or invested in it in some way, and you don't want to disappoint people in this setting of being so suicidal. So I'm reviewing some of the specifics about this study because it is a unique study. I think it is, as far as I know, one of the very few double-blind, placebo-controlled trials of patients who were suicidal and who were washed out of medications. I mentioned that in the study design, but if I was seeing this and I was in your position, I would be looking at that and going, what? You took a bunch of suicidal patients and you took them off medications for a week? And so the number of the design features that we have in this study are reflective of a very careful and complicated process of planning that reflects what I think of as a science safety trade-off. There are not very many studies that have done double-blind randomization in suicidality and in patients with suicidality. And we would like to maximize two things, scientific rigor and subject safety, but often those two are pushing in opposite directions. So we'd love to have people treatment-free when we do whatever interventions we're going to do. That's great scientifically. It's not so great, from the safety perspective. We'd like a placebo, right? Or something, a sham if you're a brain stimulation treatment. Well, that's great rigor-wise, but it's not so great safety-wise. And we'd like to study people for a long time. Again, great from the point of scientific rigor, not so good for safety. And we'd like to study people who are very suicidal. And of course, that poses some questions and issues from this safety side. So I have to say, I sat on an NIH review committee for many years that reviewed, it was called the Treatment Assessment Committee. So we got all these treatment proposals, and essentially all of the suicidality targeted treatments came through that, and they always got rejected. And they got rejected because they failed on either the safety or the science side. The studies were open label, people were left on their usual medications, all kinds of different ways to address the safety issue, but failed on rigor. Or they were strong on rigor but failed on safety because they were taking people off medications and so on. Placebo-controlled studies that, there were concerns raised about the placebo. So there actually have been a set of guidelines published by NIH about how to carry out studies, including suicidality. And the way that we succeeded in getting our grant funded and was able to plan a study that was acceptable to our IRB and to the NIH from the committee and program is that we followed these guidelines very carefully. And we had actually done pilot work to show that we could safely take patients with suicidal ideation off medications for periods of time, and we could give them placebo. We had a small pilot trial where we implemented these safety recommendations of NIH and safely treated a modest number of people. That ended up being sufficient to convince the review committee to allow us to do this study. There are some other features that are consistent with the NIH recommendations that we included, is that everybody is getting treatment. They're getting an antidepressant, and they're getting super closely monitored throughout this whole study. And so what our trial involved was an add-on therapy, which created a level of security for everyone. There was nobody who was getting placebo alone. And but the taper was complicated, and I have to tell you, my blood pressure was probably 10 points higher when I was doing this trial than it is now. It was an anxiety-provoking experience, and but at the same time, I felt like it was really important to do because it's so critical that we get information about how to address this critical public health problem. So we ended up having 103 people randomized, and we had, as often is the case, people dropping out of the study for various reasons. Ended up with 82 people who completed. We did a test of guessing to see, making sure that our blind was adequate, and in fact it was. But the baseline characteristics of the subjects were balanced across the two groups, this open and the placebo group. There were no statistically significant differences, but this was the most important outcome of the study. With over 100 people in the study who were suicidal, we didn't have a single suicide attempt. And part of this is, that we were carefully monitoring the people and communicating with them very frequently. And we had agreements from people that there was a person in their lives who could watch them. That was another part of the study that helped us be able to implement this in a safe way and in a secure way. So that, it was fantastic from a safety point of view, but it doesn't address the efficacy question. Here's the findings on sleep. Now, it's not a surprise to anybody that a medication that's FDA approved for insomnia helps sleep. there's been this treatment has been, evaluated in multiple settings, and in fact, it did help sleep. You can see that the insomnia severity index score here, which is a composite, it's a 5-item scale, each item is rated 1 through 5. It's been validated across a number of the usual parameters for validation that we would like to see measures be validated with. And higher scores is more insomnia. So you can see here that the placebo group had significantly more insomnia throughout the study period than the placebo group, and showing that our trial was adequate in that the drug achieved its intended effect, which now allows us to test the hypothesis we're really interested in, which is, does improving sleep improve suicidality? The answer to that was, we did find statistically significant advantage on the Columbia Suicide Severity Rating Scale. Higher numbers is more suicidality, and you can see the placebo group had higher suicidality over time than placebo, and than the zolpidem group. How high? Is that clinically meaningful? I don't know the answer to that. Does this mean like one more person would commit suicide? We don't. The data it wasn't possible to really analyze it in that way. This was, I think, a first attempt to establish proof of concept in 2 ways. One is that it's feasible and safe to do a double-blind placebo-controlled trial in a group of people who have suicidality to assess what treatment of insomnia and whether that might impact outcome, and to see if there is an effect is the other aspect of the proof of concept. One thing that I sort of struggled with after the study was over is the idea that while we looked at sort of the entire study period as in order to assess outcomes, it does seem to me to be the case that if you can have an advantage at any time point with respect to suicidality, that is a big win. And that in some ways it makes sense to assess this at individual time points, because at any single time point that you have a win, you might be saving lives. I think it was notable that pretty much everybody entering the study got improvement within 1 week. A lot of people did. And this was not significantly different in the 2 groups. I think just being in the study and having the structure and support led to improvement in a lot of people, which is a challenge for any double-blind placebo-controlled trial with generally any psychiatric condition, and it seems to be true with suicidality as well. We had a second measure of suicidality in the study, which was the Beck Suicide Ideation Scale, and it turns out, it showed an effect only at 1 time point, but the overall effect, as in the pre-planned analysis, was not significant. This is another thing that sort of brought my attention to the idea that, doesn't it matter that at week 6 there's a statistically significant effect, and that could that potentially mean it translates into saved lives? Now, the fact that this wasn't an a priori hypothesis means we can't put any stock in it. But for hypothesis generating and for thinking about how I would study things in the future, I think it led me to think it probably makes sense to formulate outcome hypotheses in a different way for suicidality than for depression. Yes, suffering matters with depression, but it's not the same kind of thing like at 1 time point versus another. It's not the same thing as like having a difference in intensity of suicidal ideation that could lead to an attempt at some single time point. And what I think the lack of consistency across the 2 measures is of interest. It could be that the effect is not as robust as I would hope. It turns out that we learned after doing this study that and across a number of contexts, the Columbia Suicide Severity Rating Scale seems to be a more sensitive measure than this Beck scale for suicidal ideation. So this is probably less capable of picking up an effect than the Columbia was. So, my conclusion from this study is that there's some evidence that treating insomnia might decrease suicidal ideation, and on this Columbia Suicide Severity Scale. And if you believe that there is some interest in trying to view insomnia as a modifiable risk factor, that it makes sense to treat it in clinical practice. But there's there's a couple of issues. One is we didn't study actual attempts. You have to do a very large study to show a statistically significant effect on attempts. This is only ideation. And again, as mentioned before, a change in ideation of the size that we saw is not necessarily meaningful in terms of a number of attempts. That's one question. The other question is, people may be aware that there is class labeling for all of the hypnotics, the medications typically used to treat insomnia. These are all the FDA-approved insomnia medications that suggest that they might increase the risk of suicide attempts. And it was very interesting when I became aware of this some years ago. It was not at all clear to me where it had come from. And I'd been doing work for years with a lot of these agents, research work, and for a number of them, I was involved in their FDA approval process. And it just was not at all clear how that came from, and how that came about, where it came from. And it's not that there is systematic data that prove that that's the case by any means. But I will get to that story in just a second. What it does mean is that you could always use cognitive behavioral therapy for insomnia. And there are only open label data on cognitive behavioral therapy to date. And the other issue is that cognitive behavioral therapy doesn't work on the first night that you start it. It takes 3 to 4 sessions, which often unfold over 3 to 4 weeks at least, maybe. In clinical practice, usually follow-up appointments may be even farther apart than that. So it's potentially usable, but not likely to have an effect immediately. And in the case of trying to address suicidality, that could be very important. Back to the question of using the drugs then, which are of high interest because of their rapid speed of effect, which is typically first night. Is it safe to use them? So the same group that did this trial also did a review of the question of whether there are really solid data supporting the question of whether hypnotics increase suicide risk. And the methodology we used was to search PubMed and the Web of Science for trials and data and whatever, but that's not enough because a lot of this stuff doesn't show up in trials. It only emerges in things like the post-marketing surveillance. So the FDA has a mechanism by which if you have a problem with a drug, relatively newly prescribed, the company has to report it, and there's a mechanism for people who spontaneously want to report to be able to do so. And then we also contacted the FDA and requested that we get all the case reports for hypnotic-related suicide deaths that had come through its adverse event reporting system for that reason. So we were trying to cast our net as broadly as possible to try and pick up the evidence that there might be suicidality risk and increased in people who take hypnotic medications. There are some studies we found that suggest that there is a correlative association of taking hypnotics and having an increased risk of suicide. The problem with those studies is none of them controlled for the potential confounds. That is, they didn't control for depression or other psychiatric disorders that are very commonly linked to insomnia or other medical conditions. And, it could be that the risk is conferred not by the taking of the medication, but by the condition for which the medication is being taken or a related symptom. So it was hard to draw any conclusions from that data. The other finding was that there are lots of reports of deaths occurring in people who've taken hypnotic medications, but almost none of them occurred where people took the hypnotics alone. They were always taken with alcohol or, a variety, opiates, a variety of different things. And it could be that they suggest that that's indicative of the hypnotics predisposing people to make the efforts. And it's not just suicide deaths, it's suicide attempts is the issue, that a lot of them are taken, these drugs are taken a lot of times in the attempts, and the possibility that they might have been taken beforehand and predispose people to make attempts is also a question of relevance. I think one of the most interesting things we found is that these medications can cause parasomnias, and which might in themselves lead to suicidal behavior. And parasomnia is like sleepwalking, sleep talking, an event happening during sleep where there is some partial consciousness in terms of function, but generally not awareness and nor memory for the event. And as typically we experience with like sleepwalking. And the interesting thing is that these cases appeared to be suicide. Sometimes were associated with suicide attempts in people who were not known to be suicidal, or there was, they denied being suicidal, in terms of after the fact or whatever. And sometimes people died and there was no way to get more information about it. And as I mentioned earlier, it's possible that the people were making an attempt and just didn't mention it because the self-report is not perfectly reliable. In fact, it's got significant limitations. But there was the hint in this data that they might be predisposing factors for some people that otherwise would not make an attempt to harm themselves. So I would say overall, our conclusion is that there is some evidence that supports that hypnotic medications probably confer a small but finite increase in risks. And the issue remains open about whether there might be increases in suicidal ideation or attempts associated with specific hypnotic medications, or whether this is overall effect. But then the other question remains is if there is some sense that improving insomnia might decrease risks, we need to sort of figure out a way to balance those risks against each other. Is there is there an overall advantage of using hypnotics to help people sleep better because it decreases suicidal ideation overall, despite maybe some factors that increase risk, or vice versa? So I'll stop there. There's lots to talk about on this subject, and hopefully there's questions you have or points you'd like to raise, we can talk about.
Thanks, Andrew, for that. No questions have come through the chat, so we can just sort of open the floor. But I had a question just kind of going back to the beginning of the slides about the individuals who did not endorse any suicidal ideation, but had insomnia as a predictor for the suicidal behavior. And there may not be much in the way of studies in this regard, but so maybe it's just your impression. I'm just curious if there's certain types of insomnia or quality of insomnia that may be more specifically related to later suicidal behavior.
So just to clarify, my two patients who killed themselves did not have insomnia and as a predictor. They just didn't report suicidal ideation, or they contracted one of them contracted the same day. And so, but to answer your question generally, it doesn't appear that there's a specific phenotype of insomnia that is linked to suicidal ideation or behavior in terms of trouble falling asleep or staying asleep. Some have argued that one of the reasons that insomnia might predispose people to suicidality is because people have relatively less effective executive function during the night period, just based on circadian variation of functions and perhaps some component of sleepiness, occurring because people had been asleep, woke up, and then and then were affected by perhaps their prior sleep to some degree. I don't know of any strong data that supports this, but there's a little bit of correlative data that leads people to hypothesize, some people to hypothesize that it's being awake in the middle of the night. That's really the issue. But that's about suicidality, in the night. It's not about suicidality generally. And I really have not seen anything that speaks to a specific phenotype of sleep problem otherwise that's linked to suicidality.
Thank you for that.
Yeah.
Nicholas, I don't know if people can come off mute the way it's set up, but if that's possible.
Yes, they can unmute themselves.
Okay, so feel free to do the chat or just come off mute if you'd like.
Can I ask a question?
Please.
Dr. Krystal, it's Emma. I'm wondering I think there's a lot of cases that have made, we should try to treat insomnia in our suicidal folks, and whether the best way to do that is with something like a hypnotic that in overdose in combination with other things is problematic, or some of the other kind of ways that we treat insomnia commonly that maybe are less problematic. And I guess more specifically, would you recommend, if we're going to use something like a hypnotic, to prescribe it in someone like on a weekly basis, or some way to make it less of a loaded gun just by having less of it around? Or do you think that that's not really a necessary precaution?
So, I think that one problem we have is of the options, I think the best one would be a non-medication intervention. But as I said, I'm concerned that if you have a person who's suicidal and you're treating the insomnia for that reason, it might be too slow to do things like cognitive behavioral therapy. So are there ways to give medications that are safer? The issue of the people combining medications with other things, like the benzodiazepines with other things, could be controlled by relatively modest sized prescriptions, I think, to a degree. I think that the lethality, if you look at the sort of toxicology data and the experience from single drug overdose, the drugs in themselves are actually extremely safe. So it is only primarily in combination. And I think from my point of view, it's a matter of judgment of a particular patient, whether or not they are likely to be a person who would be combining a medication, medication with other things. But there's no data I know of about, strategies that might mitigate risk. I think this common sense thing is what you propose, to prescribe things in small amounts, as small as possible.
Thank you.
I hope that answers your question, Emma. I'm not sure that it does. So, one of the challenges we face is there's not a lot of research done on this topic, and there's not a lot of literature available to draw on. The study I presented there is the only double-blind trial that exists. And there's one open label study of cognitive behavioral therapy for insomnia, which showed a decrease in suicidality, but it was a open label. And as you saw in our study, people on placebo improved significantly with their suicidality entering in a trial, and perhaps getting fluoxetine, although hard to know how much that might have contributed.
Hi, this is Aoife. Hi, Andrew.
Hi, Aoife.
Really interesting talk. I was just wondering if you, so I was really taken by your mention of your blood pressure being up while running the study, and it kind of reminded me that, you know, we have to grapple with this issue in all kinds of clinical trials. What will the cutoff be for suicidal ideation, for suicide risk? And given your experience running this study, what do you think it should be in our studies, you know, if we're focused on depression, or in my case, PTSD, where good proportion of the population would have high levels of suicidal ideation, attempts? Where do you think the balance is between risk and generalizability?
So this is a good point you're raising. This was one of the easiest studies for me to recruit for. I did not predict that ahead of time. I thought, you know, it's going to be tough to find people who have depression and insomnia and suicidal ideation. It wasn't. It's because that combination is pretty common, and they're excluded from all other studies. Nobody, you know, no other study that I was doing or anybody else was doing would allow people with even mild suicidal ideation to qualify. And it did make me realize that we have a huge problem in our clinical trial literature and in our research literature, that they don't apply to people who have suicidality, even though they're common symptoms of the problem. And this is one of the, I think, gaps that leads the research literature to not reflect how things perform in clinical practice. My thought is that, you know, that it is possible. One of the things I came away from this study with, and it may be the most important thing that I learned, is that it is possible to do a study with people who are suicidal following certain basic methodologic strategies. And, you know, not all studies can implement them, but many can. And they, you know, and there's this guideline it was very useful for helping us design our study. And my thought is that we ought to be including at least mild suicidal ideation in our trials of conditions like depression and PTSD, and so they are applicable to clinical practice. And not leave this huge and important portion of the clinical population out of our research efforts entirely. So I think that I would be in favor of like ending the practice of eliminating people with any kind, like for most studies, you can't even have suicidal ideation in the last year or something like that. And, you know, I think, but the problem is it takes a lot of effort, and there will be people who kill themselves in studies. I went into the study accepting the fact that we would likely have a suicide death in our study. I mean, you don't do a study like this if you aren't willing to accept that. It's, you know, just like I'm known, you know, I treat patients with depression, that there will be a suicide death in my patients. And I said I had two, and they were very difficult for me, but they are a reality. You don't treat people with these problems if you aren't willing to accept that.
Yeah, thank you. That's really helpful reflection.
I had another question, just thinking about sort of clinical practice across maybe different disciplines or areas of medicine, whether there are challenges in terms of just the app when you're assessing a patient or working with a patient as to, you know, the variability of what is insomnia, or in terms of chronic insomnia. Like, you know, is the definition just too broad, broadly deployed? That can create a problem in terms of treatment, or I don't know if this has even been studied, but I would think, you know, because it's both sort of a clinical term as well as just a common everyday term out there.
Yeah.
And I don't recall whether in the DSM-5 how lined out it is or elsewhere in diagnostic tools.
Yeah, so I think the data on this suggests that people who report sleep disturbance, at least occasionally, is extremely high. It's more than 50% of the population. The prevalence of insomnia that meets the criteria laid out in the DSM-5 is about 15%, 15 to 20%. And the key to those criteria are that the problem is persistent, requires 3 months of problems, at least 3 nights a week, and that it's associated with daytime functional impairment. And the daytime functional impairment part is I think the most important differentiator of clinically significant insomnia versus what most people experience. But it is a little gray there because most people, when they have a bad night of sleep, don't feel so great during the day. So I see some people where it's not meaningful, but for a lot of people, their sleep translates into symptoms, and then it becomes persistence. That's the clinically differentiating factor. Did I answer your question?
Yeah, I think so. Thanks.
And so when we do start trials, with insomnia, we generally include that subset. But there are a number of things that are in the differential diagnosis that are not insomnia that have to be ruled out, and we generally, which we did in this study, like for example, obstructive sleep apnea. Or people who have restless leg syndrome or periodic limb movements of sleep. So you have to do a sleep study to pick up things like that. And some people have a circadian rhythm problem. That is, they tend to stay up late and sleep late biologically, and they're trying to sleep at an adverse circadian time. That is not insomnia. It's a circadian rhythm disorder, although many of those people develop insomnia on top.
Well, I think we have a little more time left, but I don't see any other questions coming through the chat. If anyone else has anything they want to bring up or ask, otherwise we can finish up and then give back some time for everybody. So with that, then we'll go ahead and finish up. Andrew, Dr. Krystal, thank you so much for your presentation today.
My pleasure.